Ladies and gentlemen, boys and girls, with great pleasure, we've got Dr. Theo Vos with us from IHME. So this is the big modeling group out of Washington that we're all using this model. So we'd actually thought we'd get one of the professors who, made this thing, tell us, how accurate it is, what are the inputs, what are the outputs, and then I wanted to look specifically at some projections. So thank you for joining us tonight. It's really good of you.
Yeah, pleasure.
So Dave, do you want to take it away with some general questions for the prof?
Absolutely. And thank you for joining us. You may not know that a couple of weeks ago, we had Andrea Bertozzi from the Institute for Pure and Applied Mathematics at UCLA on, and she and I went over the kind of basics of modeling epidemics and things of that nature. So the audience has, those who've listened to that have some background in this, but maybe we can get a little bit more specific and kind of, if you could, just to kind of explain what is the basic mathematical model that you're using and sort of what are the kind of key inputs that go into that model at present?
Yeah, well, our modeling, which we started, end of February, has evolved over time. Initially, the main aim was to help health service planners with an expected time of the peak in the numbers of cases, numbers of deaths, so that they could better prepare health services to cope with the surge. Over time, our modeling has evolved because once many locations had reached the peak, many more questions came. What will happen when some of the mandates that have been imposed would be relaxed? How can we cope with the observed much slower declining cases past the peak than initially we thought would be the pattern based on just information we had at the time from Wuhan? So in order to address the shift in policy questions, we built a more traditional SEIR model onto our statistical model that looked at the daily reports of cases, deaths, and hospitalizations. And so from our model, we fit what the corresponding effective R is on a day-to-day basis that best fits in the past with the observed numbers of cases and tested cases, hospitalized cases, and deaths. We then throw in a whole lot of predictors of this effective R. What is the effect of the various mandates that were put in place? What's the effect of a potential seasonality component? What's the effect of the amount of testing that is being done? And over time, we've added more and more information as it became available, like the mobility data from all the various cell phone apps. Then we started including also information from the daily Facebook surveys on mask use, on numbers of contacts that people have. And we put it all into a single model and best predict what has happened, get the coefficients on these predictor covariates, and then build out our projections. And in more recently, we've built on a number of scenarios onto these projections. And most importantly, the three scenarios that are currently available on our website are a scenario of continued easing of mandates. Then a second one that looks at the same scenario of easing of mandates, but with a threshold where we predict that decision makers are likely to put on an emergency brake, if you like, with reimposing mandates at a certain threshold of deaths, in daily deaths in the population. And we've set that threshold at a value of 8 per million. So for instance, in the state of Washington, that would be a number, times roughly 6 million. So by the time there are 50 daily deaths, we expect that it will be hard for the decision makers to continue with easing of mandates, and they will want to use reimposition of mandates. We also show a scenario for mandated mask use, and under the potentially achievable, I'm not saying it's a realistic target, that 95% of folk would be wearing masks whenever they are within close proximity to other individuals. So you're showing on your on your shot of our model these various scenarios. Now, the first one of the continued easing and what our main projection is, including this ability to put on the emergency brake, they overlap in Washington state, but you can see that there is a reasonable advantage that could be gotten from 95% of the population wearing masks. And if you hover over the last date, it's the 1st of October in our current model. You can see what a difference in the total number of, or in the daily number of deaths, in the daily number of cases, and the total cumulative number of deaths means. Now that's, if I can see the small numbers well enough, that's about a difference between 11 and 1 death daily by the 1st of October. If you now, if you now move to, say, Texas, then you will see if you go to the same, hover over the 1st of October, you can see that's a difference between, what does it say, 250 and 20 deaths in a day. So an extremely large difference from a simple measure like using masks. If you now scroll down a little bit further, then you can see the point at which under our projections, Texas would reach this threshold of 8 deaths per million, because you can see that the brownish scenario by, 24 September, roundabout, is starting to drop quite precipitously, because that's when we project that the governor will say, hey, this is getting so much out of hand, I'm going to reimpose mandates.
Gotcha. So a couple questions related to this. If tomorrow you could have one of your wishes granted and either get a new input or improve the quality of the data for one of the inputs you currently are using, what would that be?
Well, anything that better predicts the true human behavior that we would like to measure. We have all these proxies. We use the proxies of the cell phone mobility data. We use the proxy of people reporting mask use, the people reporting how many contacts that they've had outside their household on a daily basis. But yeah, you really want to know is when they have a contact, how did that happen? Were they having the contact, wearing a mask? Was the other person wearing a mask? What was the distance? All of that is, of course, much more complex. So we skirt around the issues by, looking at all this available information and seeing in our model how much of it helps to predict what we've seen in the past. And out of all the predictors, the ones that really come up as most informative are the seasonality pattern. And we've mirrored this on observed weekly deaths from pneumonia. And we've been able to do this in the US states, in states of Brazil, in Colombia, Guatemala, New Zealand. Those are the places where we had this historical data on weekly deaths by cause available. And that pattern of seasonality with a peak in the winter months and a trough in the summer months, and of course, you know, a similar pattern by summer and winter, but inversed in terms of calendar year on the southern hemisphere. Turns out to be extremely predictive of what we've observed, and so it learns from the patterns in southern hemisphere countries, particularly in Latin America. It also sees the patterns from the northern hemisphere. The other one is the amount of testing, but again, you know, that's a proxy for what we would really like to be able to measure. That would be, you know, how much testing is being done, how many positive tests, how long did it take for the test results to become available, how good is the contact tracing, and how quickly are the contacts being tested and you know, followed on with isolation measures. But you know, just the volume of testing is, you know, that has increased a lot with greater availability, is, you know, quite a predictor, an important predictor in the model.
So two more quick questions. First, does your modeling have any elements that look at whether the probability of spread is sort of homogeneous throughout the population, or the concept that it's sort of quantized in super spreaders, so that whatever your effective R is, that it's not really just kind of like every single person who has COVID achieving more or less that R, but rather there's one person who's got an R that's 100 times that, and then a whole bunch of people whose R is very small, and the overall R is kind of this averaging of these two separate phenomenon. Is that built into the model, or is that something which is not quite?
No, we don't really make that explicit, but you know, this concept of the effective R indicates it's, you know, it's that it is a moving target, that it changes on a day-to-day basis, and B, that it reflects what happens in the population on average. But we do know that you know, this with all these isolated outbreaks, that, you know, that is a simplification of many, you know, smaller epidemics that are happening and that are having, you know, quite an important impact. If you look at, you know, all the deaths that have occurred in nursing homes, all the outbreaks in meat plants, or you know, in choirs, or, you know, there's so many examples. You know, it's actually a much more complicated story. It's also, it's also, you know, with most of the geographies for which we make estimates, you know, they're very heterogeneous in how the epidemic is evolving. You know, like, good example is a big state of like California, where it is at the moment looking really bleak in the southern part of the state, and you know, much more of a northern pattern, if you like, with an abating epidemic and cases coming down and deaths coming down in other parts of the state.
Right.
So what we really want to do, and, you know, our ambition is over the next couple of weeks to achieve that, is to you know, extend the model to reflect counties in the US. But yeah, you can imagine that throws up a few challenges with dealing with smaller numbers, and not just small numbers, but also with wildly fluctuating numbers. So I guess on a wish list of what we would really like is if all the measurement noise, with, you know, one day reporting 10 deaths, the next day 0, and then again 25 deaths, and then going back to almost nothing, if, you know, that would you know, would at least be removed partially, because we now have to do a lot of you know, adjustment of all these fluctuations of how the data come in.
Fair enough. And finally, The effect of mask wearing was pretty compelling on the graphs that you showed, and unfortunately, this has become a political issue. And a number of modelers have had police, people have been getting police protection because of death threats for people who are saying we need to wear masks, or predicting, that we need to have more curfews or more restraints. Have you guys experienced any of that? And what are your thoughts about that?
Oh, no threats. At least I haven't personally yet received those. As we've been progressing with our modeling and the sort of exposure we've had, there have been rather nasty messages sent to some of the folk in the institute. But what I notice is that even in places where there was most of the resistance to measures like this, the IDs are slowly changing. And I think, just observing the sheer magnitude of the problem in places like Texas and Arizona and other parts of the South, but also some of the more Western states. I think even people who initially had reservations about masks are probably having a more willing attitude towards them, and hopefully that sort of concern will overcome some of these political dimensions that unfortunately got attached to what is, in principle, not a very political public health measure.
Can I ask you about the robustness of that data about masks? Because we initially were getting reports, don't worry about masks, and then very strongly from the CDC, from the White House physicians at least, saying masks are very important. So where do you get your data on masks from, and how robust is it?
So this is a meta-analysis, or if you like, meta-regression that we did on all the available studies that have looked at mask use. We cobbled together all the unique studies from 2 meta-analyses that other people had prepared, and used our more advanced Bayesian meta-regression methods to then isolate between studies in different settings what the effect is of wearing simpler types of masks as opposed to higher grade medical masks, and in a general population setting as opposed to in a healthcare setting. Because these 40-odd studies, they all were done in different types of settings using different types of masks. But with these meta-regression methods, we were able to isolate the effect of what we think is most important in modeling what happens in the general population, and that is about a 1/3 reduction in the risk of transmission. Now, these studies were done, there's only one of them that was done with COVID as a disease outcome. All the other ones were done from the earlier SARS, from MERS, and in all these different, all these different characteristics. But we think the signal is very strong for a protective effect of masks overall. The signal, we think, is also strong enough for us to put out these estimates on the protective effect, even if people use simpler cloth or paper masks.
Because on your modeling here, I'll just share again. Hang on, I'll share the screen here again. I'm just so impressed by. So we're looking at, this is for all of the US here, and here's July 1st, and the projections sort of flat and then start to go up. But mask wearing drops this line substantially, more than the other sort of physical distancing measures, stay-at-home measures, more than any of those. It looks like by a significant factor. Is that accurate?
Yeah, well, what happens is that if you reduce the risk of transmission, you bring down this effective R to more manageable levels. You know, if it was above 1, you may be able to bring it below 1 and therefore greatly reduce the spread. If it was already below 1, but you know, intending to creep up, say, because of the seasonality pattern that we built in, then mask use can counter that effect. But it really depends on where you are, because if you look at our graph for New York, then the difference between mask use and continuing easing of mandates is extremely small. So it's depends on where you are at the stage of the epidemic, what the implied spread in the population is at the moment, how much of an effect you can have. And with, you know, with the way infectious disease modeling goes, is that if you can manage to keep this effective R below 1 for as long as you can have great benefits going forward, even if there are other influences that want, you know, because of increasing mobility, seasonality, or other factors that are pushing up the potential risk of transmission. The masks can dampen that effect and keep the effective R below the magic threshold of 1 for as long as possible, and hence have such dramatic effects on the projected numbers of cases and deaths.
So you've talked about seasonality, but I don't think you've explicitly said it. So your model assumes that there is seasonality and this is going to get worse in North America in the winter.
Yes. And we actually you know, have the data for North America state by state. What we've done for all our other locations where we did not have the available historical data, we predicted out the amplitude of this pattern of higher risk in winter and lower risk in summer based on latitude. So the further away from the equator you are, the bigger the seasonal pattern is, and if you're close to the equator, there is very little fluctuation.
Okay. And what about indoors versus outdoors? It appears from the lay physician, as it were, that being outdoors is quite protective compared to being indoors. Looking at places like New York, Chile, where I know those cities and how they work, particularly when it's cold. Lots of people are inside. Lots of people are using a subway system. In California, part of our protection, I think, was that we drive cars and we've got more open spaces. Is that true? Does that come up in your modeling? Indoors is bad, outdoors not so bad?
No, we don't have anything to take that explicitly into account, but it's, you know, it is implicit, I think, in the seasonality pattern that during winter more people are inside, and you know, there's lots of, you know, justification to think that you know, it's better to be outside if you do this, have the same type of contact compared to inside, if only because, you know, with even a little bit of a breeze, the aerosols that may contain virus are likely to be blown away, and the time that you may be in contact with these infected droplets or aerosols is reduced. So yeah, I do think that you know, there's good reason to believe that, you know, far more protection is needed in confined spaces than in outdoor spaces, but you know, the risk is still there when you come into close contact with an infected person, even if you're outdoors and even if there's you know, quite a breeze.
Dave, do you have any last questions? I don't want to take too much more time.
Yeah. Just one more question. Assuming that the vaccine takes some time to arrive, which I think is more probable than not, I think the message of your current predictions, which of course only go to October, but I imagine you guys have looked further down the road, is that if we wear masks fairly religiously, we can keep this at a manageable level, and we may be doing that for a very long time. because you're certainly not moving towards herd immunity with any of your models. And in the absence of a vaccine, we're going to be wearing masks for a while.
Latin America is heading towards herd immunity. I would not be surprised if by the end of the year, the proportion of the population exposed is in the order of 60–70%.
Wow.
We are going to extend what we show of our model to the 1st of November later this week. We set ourselves a 4-month forecasting window, so that will shift this week. Our models actually that we look at internally go on until the end of the year. So we have an idea of what we think is likely to happen, but of course, the further out you go, the more uncertain the projections become.
You talked about Latin America herd immunity, 60–70% of people infected. Do you have anything to say with your ID hat on, or any hat, about the recent article that came out from China that suggests that if you're an asymptomatic carrier, you have low IgG levels that appear to drop off very quickly compared to if you're a very symptomatic, higher levels that last longer?
Yeah, so
what does it do to your model?
Well, yes, they've indicated that by 3 months there's much more of a drop-off in IgG levels in people who had no symptoms or very low amount of symptoms. That does not immediately translate into a lack of immunity, because there's also the cellular immunity, and it may well be that if triggered by new exposure, that that will induce a boost of the immune system to keep the infection at bay. But yes, we're closely following all this information. We're closely following all these antibody studies it's a great way of validating our estimates by looking at what the total exposure in the population is. And of course, it is of mega importance in predicting what the likely protection of a vaccine is going to be. So there's a lot more that we need to learn about this, but yeah, I tend to be optimistic. So I'm still holding out for a much rosier future come the release of the first vaccines, hopefully by the end of this year, early next year.
Yeah, I hope you're right, because the alternative is that this is going to suck for a long time.
Yes, I think, but even if we get a vaccine, and let's say, it may only be, 50%, 70% effective, or maybe take the edge off the more severe endpoints, it will still be around, and we'll need to live with this for, years to come.
Yeah, it's going to have to help us out and mutate to a more benign form or something. Look, thank you so much for your time and for your work and for your group's work. We'll be continuing to follow your model, and maybe later we'll be able to get you again when you've got some more of those inputs.
Pleasure, and always good to hear an Aussie accent.
Thank you.